control. So respiratory rhythms are going to be regulated by higher brain centers, chemoreceptors, and several other reflexes that we will touch on. Neural mechanisms, they involve neurons in the reticular formation of the medulla and pons. The medullary respiratory centers are clusters of neurons in two different areas of the medulla, and they are most important, or the most important groups are the ventral respiratory group and the dorsal respiratory group. The ventral respiratory group, VRG, is a rhythm-generating integrative center, and some recent evidence suggests that the forced expiration involves a separate group of neurons compared to passive respiration. They consist of networks of neurons in the brainstem that extend from the spinal cord to the pons medulla junction. They set eupemia, which is the normal respiratory rate, and rhythm, which is typically about 12 to 15 breaths per minute. It's going to involve inspiratory neurons that excite inspiratory muscles through the phrenic nerve, and that would be the diaphragm, and the intercostal nerves, those would be the external intercostals, and the expiratory neurons inhibit inspiratory neurons. The dorsal respiratory group is a network of neurons located near the root of cranial nerve 9. That group integrates input from peripheral stretch receptors and chemoreceptors, sends the information to the ventral respiratory group neurons, and we don't know too much about these dorsal respiratory group. Pontine response respiratory centers are neurons. There are neurons that influence and modify the activity of the VRG. They act to smooth out the transitions between inspiration and expiration and vice versa. They transmit impulses to the VRG that modify and fine-tune the breathing rhythms during vocalization, sleep, and exercises. When lesions happen in the pontine respiratory centers, you get apneuristic breathing, and patients take prolonged inspirations. There is figure 22.26, which I encourage you to look over in your text. Generation of the respiratory rhythm. Origin of breathing rhythm is really not fully understood. The current hypothesis is that there are pacemaker neurons in the ventral respiratory group that control that intrinsic rhythmicity. The most widely accepted hypothesis is that we get reciprocal inhibition of two sets of interconnected pacemaker neurons to generate the rhythm, so that each neuron set controls the other, and that ensures rhythm. Depth is determined by how actively the respiratory center stimulates the respiratory muscles. Greater the stimulation, greater number of motor units we excite, increased depth of inspiration. Rate is determined by how long the center is active, and both can be modified and are modified by changing body demands. The respiratory centers are affected by chemical factors, the influence of higher brain centers, pulmonary irritant reflexes, and an inflation reflex. Chemical factors, the most important of all the factors affect depth and rate of inspiration, are changes in the level of CO2, oxygen, and pH. Levels of those chemicals are sensed by central chemoreceptors that are located throughout the brainstem, and peripheral chemoreceptors that are found in the aortic arch and the carotid arteries. The most potent of these signals is actually the CO2 levels, not the oxygen levels. If blood carbon dioxide levels rise, which would be hypercapnia, the CO2 would accumulate in the brain and join with water to become carbonic acid. The carbonic acid would dissociate, releasing hydrogen ions, causing a drop in pH, which is increased acidity. That increased hydrogen ion stimulates central chemoreceptors in the brain center, which synapse with the regulatory respiratory centers, and those respiratory centers would then increase depth and rate of breathing, and that should lower the levels of carbon dioxide in the blood, bringing the pH back to normal. If blood CO2 levels decrease, respirations would then become slow and shallow. Apnea is a breathing cessation, stopping, that can occur when CO2 levels drop abnormally low. Swimmers sometimes voluntarily hyperventilate to enable them to hold their breath longer, because that hyperventilation causes a drop in CO2 levels, which causes a delay in the respiration as CO2 levels need to build back up. That can be dangerous, though, if that can cause drops in oxygen levels, however. Again, here is 22.28, and I would encourage you to look that over in your text. Hyperventilation then is an increased depth and rate of breathing that exceeds the body's need to remove CO2. Can be caused by anxiety attacks, leads to a decreased level of CO2 in the blood, hypocapnia. That causes cerebral vasoconstriction, cerebral ischemia, giving you dizziness and fainting. Early symptoms would include tingling and involuntary muscle spasms in the hand and face. And a good way to treat someone who is hyperventilating is to have them breathe into a paper bag and then rebreathe that air, putting more CO2 back into their lungs. Chemical factors that influence rate and depth. The oxygen, peripheral chemoreceptors in the aortic and the carotid arteries sense atrial oxygen levels. Usually oxygen declining has only a slight effect on ventilation, because there is a huge oxygen reservoir bound to hemoglobin. Remember, even in venous blood, there's 75% saturated. So it requires a substantial drop in arterial partial pressure of oxygen, and that means below 60 millimeters of mercury, to stimulate an increased ventilation. And when those are excited, those chemoreceptors cause the respiratory centers to increase ventilation. Arterial pH. pH can modify respiratory rate and rhythms even if CO2 and oxygen levels are normal. They're going to be mediated by peripheral chemoreceptors, so decreases in pH might reflect CO2 retention. It could be the accumulation of other acids such as lactic acid or ketone bodies. And the respiratory system is going to attempt to control the pH of the blood by increasing respiratory rate and depth. So, rising CO2 levels are the most powerful respiratory stimulant. Normally, oxygen levels affect breathing only indirectly by influencing peripheral chemoreceptor sensitivity to changes in CO2. When the arterial partial pressure of oxygen falls below 60 millimeters of mercury, it becomes a major stimulus for respiration through peripheral chemoreceptors, and changes in arterial pH result from CO2 retention or other metabolic factors will indirectly work through peripheral chemo or be detected by peripheral chemoreceptors. The higher brain centers, there is hypothalamic control that acts on the limbic system to modify the rate and depth of respiration. For example, you can hold your breath when you are angry or gasping with pain. Changes in body temperature will change the rate. In the cortex, cortical controls direct signals from the cerebral motor cortex that bypass the medullary controls, so you can have voluntary breath holding until the brain reinstates breathing when CO2 levels become critical. There are pulmonary irritant reflexes, which are receptors in the bronchioles that respond to irritants like dust, accumulated mucus, or noxious fumes. Those receptors communicate with the respiratory centers through the vagal nerve afferents. They promote reflexive constriction of air passages, and same irritant triggers that can cause a cough in the trachea or bronchi or sneeze in the nasal cavity. The Herring-Bauer reflex, the inflation reflex, there are stretch receptors and pleurae in the airway that are stimulated by lung inflation. They send inhibitory signals to the medullary respiratory centers to end inhalation and allow expiration. And that probably serves as a protective response so that lungs are not overinflated more than a normal regulatory mechanism. So there are a number of neural and chemical influences on the brainstem and respiratory center. And again, I would encourage you to check this figure out in your book.